Okay. Wow. I really don't need to be amplified for like the 6 people who are here. So I'm gonna speak about not so much research work. I have done some survey research on these issues, but that's not going to be the focus. This is going to be a much more sort of policy-oriented conversation, and I hope it is conversational, especially with 8 of us in the room. We should just be able to talk about these things rather than sort of a formal lecture. This is what I want to try and accomplish today. I'm going to give an extremely brief overview of some of the legal and regulatory issues associated with disaster response, both in country and outside the U.S. And then I'm going to speak more broadly about these 3 sort of big ethical issues that each one encompasses a lot. But we'll start by talking about the professional responsibility to provide care despite some danger to oneself, what's been called the duty to treat. And as it turns out, not everyone buys this in disaster situations and outbreak scenarios. It's pretty common for health professionals to leave the area in the same way that many other people want to try and leave the area for obvious reasons, perhaps. So we'll talk a few minutes about that, and then a few minutes on what I guess is the classic ethical dilemma in public health in disasters, which would be restrictions on personal liberties. These are things like quarantine, isolation, restrictions on travel, that kind of thing, loss of rights of individuals in the context of disaster response. And then we'll end with the third, which is also the big classic dilemma, which is rationing. And what do you do when you don't have enough to go around? Which is a pretty common dilemma in disaster scenarios. So just as background, the U.S. Constitution in the 5th and 14th Amendments guarantee due process and equal protection. Those are the 2 pieces of constitutional law that show up over and over and over again in public health related issues, I guess. And mainly that's because they're the ones that say the state cannot infringe on your liberty without due process and without some level of protection, meaning there has to be a compelling state interest, the interventions have to be well targeted, the least restrictive means necessary. These all fall under due process and equal protection arguments as regards federal actions that might address a public health response. Most, though, of the public health response to anything is not federal, though. You all undoubtedly know this. The federal government is precluded in most instances from doing very much as regards public health interventions. And certainly when there's a disaster, the state has to invite the federal government in, right? These are not... there's a long history of this. I'll mention in just a second some of the rationale for this. But in essence, most public health emergency powers are relegated to the states. There are relatively few things that the federal government can do unless the state brings the federal government in. So the public health emergency powers are traditionally listed as these, things like surveillance and reporting and epidemiologic investigations and mandatory vaccinations and quarantines and so on. These are usually preceded by some kind of a disaster declaration. Even when a state wants to do these things, almost always the state constitution requires that the governor declare a state of emergency or a disaster or something like that. In order for a state to implement some of these coercive or liberty-restricting activities in order to respond. The state has to request assistance from the Secretary of Health and Human Services or the President via the Stafford Act if you want to have the feds involved. And that's, as I mentioned before, because of this long legacy of separation of the states and the federal powers. The Insurrection Act, which came from the era of Thomas Jefferson, precludes the federal government from introducing forces into the states. So the National Guard is a state organization, right? not a federal organization. The Posse Comitatus Act from the time of Reconstruction precludes any use of the Army on U.S. soil. And in fact, until 9/11, there was not a Northern Command. So the U.S. Army didn't, and the military did not have sort of a command post for any kind of intervention on the part of the U.S. military in the Northern Hemisphere, in our part of the Northern Hemisphere. The Stafford Act allows the governor of a state to call the president and request assistance, and that's how we get FEMA assistance and so on, is through the Stafford Act. I just put this in to sort of illustrate the way this is from a Civil Support Command briefing not too long after 9/11 when people were trying to figure out, so how would the military respond in the event that there was a really very large catastrophic disaster in one of the states, say all of the state infrastructure were destroyed? How would the federal government deal with that? So let's move now to these. So that's sort of the background, a little bit of law. Let me move now to the three ethical issues. And I'm going to start with this one about the responsibility to provide care to patients despite the fact that there may be some danger in the environment or the patient themselves may pose a threat to you. This is pretty widely assumed as an ethical responsibility among the public of health professionals. So if you survey patients, if you survey the public, most of them believe that the Hippocratic Oath requires doctors and nurses and others to continue to provide care even if the patient is dangerous, even if the patient has a contagious illness, that kind of thing. In fact, it's not in the Hippocratic Oath, and within the Hippocratic body of work, there are statements about doctors not treating patients who are potentially dangerous, or if patients are overmastered by their disease, that doctors are supposed to back off and let the gods finish the work rather than themselves. And in fact, into the time of the plagues, which is where you might have thought, the opportunity for doctors to illustrate that they really care, they're going to stick around and take care of patients despite this. For a couple reasons, it actually did not occur to people in that era that doctors would have a professional responsibility to stay and take care of patients during a plague. And in fact, in a number of places, people make the same recommendation to doctors as they do to anyone else. If a plague comes to your town, the advice is quito longe tarde, which means go fast, go far, and don't come back too soon. Right? And this was very Sydenham, very famous physician in the 1500s in England, fled the plague along often with your patients, right? So the doctors would often say, well, look, all of my paying patients are leaving town. That's what I'm going to do as well. So if you look at early codes of ethics, if you will, and there weren't really any national codes of ethics until 1847 when the AMA Code of Ethics was written. But efforts to create national codes of ethics existed and preceded the AMA and did not address this. So the 1543 Royal College of Physicians Code of Conduct said nothing about a responsibility to care for patients with plague, despite the fact it was written during a plague. So this was not a widely accepted belief. And some of this has to do with how folks outside the U.S. viewed the patient and the doctor in society. So doctors at that time, if they said, what's your ethics as a doctor, they would say, it's the ethics of a gentleman. So there wasn't an ethics specific to being a member of a profession. There was an ethics of nobility. And so to the extent that physicians were members of nobility, most weren't, they would have this sort of code that would govern their conduct. But in fact, when these efforts to start codes of ethics were brought up in England, one of the common responses was, we don't need a code. We already know how to behave. And if we did have a code, all that would do would provide people who don't know how to behave with a guidebook so that they could fake it. So it would actually be counterproductive to have a code of ethics because it would allow people who are not noble to pretend like they were. So that's very different, by the way, than the way Americans tended to think about the relations of each other and the state and classes, right? So America is largely founded on notions of social contract. And so the idea that a professional group would write out what it was that their clientele could expect of them made perfect sense in the U.S. because that's basically a social contract, right? It's saying, okay, you come to a doctor, any doctor is going to treat you in the following way, is going to have the following standards of practice, will have the following type of educational background. So professionalization really is a function of a belief in social contract theory. The idea that we as a group should have standards of practice, standards of education, standards of ethics, which we then as a group collectively promise to people. So when the AMA Code of Ethics was written in 1847, it included this statement: when pestilence prevails, it's the physician's duty to face the danger and continue their labors for the alleviation of suffering, even at the jeopardy of their own lives. And in 1912, this was actually expanded so that it said, and without regard to remuneration. So there's a very strong statement that you can trust us to stay and to help you, even at the risk of our own lives. And in exchange for that, this is a contract, right? Both sides have responsibilities. So the exchange here was, you can trust us to put your interests first without regard to remuneration, even in dangerous situations. And in exchange from that, right, you won't see quacks, you'll trust us, you'll do what we say. Very paternalistic, right? So the social contract theory, on the one hand, is very democratic, because it's a notion of, you know, we'll tell you what you can expect of us, and you tell us what we can expect of you. It was also very paternalistic, because it was basically the doctors of America, insofar as they were a coherent group in 1847, they were not, right? The AMA was a very minority organization to begin with. But insofar as it, you know, sort of, it's a process that is getting started here. The process is one of creating shared expectations. So when you come to see a doctor and you see someone with the stethoscope and the white coat, you know what their educational background is, you know what their ethics are. You don't have to interview them and find out. You don't have to check around, right? That was the idea, was that there would be a common product, essentially, that was being on offer here. And by the way, that worked. In terms of, I don't mean the whole thing worked, but I mean in terms of creating this expectation that doctors would stay around despite danger, demonstrably worked. There's quite a bit of data on this. In the 19-teens and 20s, it was being a doctor was very dangerous, right? Something like 20% of medical students ended up catching active tuberculosis. So it was common to bring home deadly disease to yourself, to your family. So it was a dangerous profession, and people went into it knowing full well that that was what they were getting themselves into. I won't go all the way through this history. It's a whole separate hour. If you sometime we can talk about the legacy of the duty to treat and AIDS and all of that. But let me just say, there have been a number of people who've written about this. And there are essentially these three ways in which people justify a duty for health professionals. And I would not limit this to doctors, by the way. I'm talking about this because it was physicians who articulated this first. But other health professional groups have similarly taken on the same type of social contract. So that's number one, is the social contract sort of theory. And that's an ethical justification. You've made this promise, and therefore you have to follow through on that promise. And by the way, you've accepted the prerogatives of being a health professional. And in accepting those prerogatives, you've also accepted the responsibilities, and this is one of the responsibilities. A second one is the sort of lifeguard idea, which is you have special training which makes you particularly well suited to taking care of people who may be dangerous to you. You know how to use personal protective equipment. You know how to take care of people in general. So, once trained in that way, you have a moral responsibility to use your training. And moral obligations can arise from the fact of your training, the proximity of you to someone in need. So there's a famous paper about a lifeguard, and why does the lifeguard have different moral obligations than a person who's just standing on the beach in terms of going into a dangerous current to rescue someone, right? So, and then the third is non-discrimination, and this is much newer. But the idea that you cannot discriminate against people because they are a little bit dangerous to you is quite real. This came up in the era of AIDS in particular, but there's a Supreme Court case that you can't just say, well, because patients with AIDS are contagious, I choose not to take care of them. That is illegal under the Americans with Disabilities Act. And it's been taken all the way to the Supreme Court and upheld as illegal. So that's both a legal and a moral rationale. That it is wrong to discriminate against patients who have one contagious illness versus some other illness if you are qualified to take care of them otherwise. So this raises this question, of course, so what are the limits? Because obviously you don't want doctors, nurses, others sort of running into burning buildings or the equivalent of burning buildings in the same way, by the way, that we don't want other public servants who have a responsibility to do dangerous work to be excessive in their heroism, right? At some point, your basic duty turns into something heroic, and at some other point, that heroic action turns into a martyrdom action, and at some point, it's just being stupid, right? And these are gray. There's a spectrum here, though, right? So where does duty turn to heroism, and where does heroism? And there's, as I put on the slide here, not any one exact threshold. I think there's broad agreement that there is a responsibility in general for health professionals not to put themselves in such danger that it's essentially guaranteed they won't ever be able to take care of another patient after they finish taking care of this one. Right? So giving up your own life in order to save that patient is, in the long run, bad for society. It's bad for you in the short run, but it's bad for society if that were to be the standard. Right? Because you actually want health professionals to be able to continue caring for other people in the community beyond the one person. There's also a broad agreement amongst ethicists and policymakers that if you want doctors and nurses and others to take on this ethical, moral responsibility, then there are reciprocal responsibilities for institutions, government, hospitals, et cetera, to provide personal protective equipment, to vaccinate people who are going to be taking care of patients with contagious illness if there's a vaccine, and so on. And I'll come back to liability in a few minutes. So that's the first of these three R's. The second is restrictions on liberty. So let's. I forgot. I got a couple other slides here, but I'm not going to say much about these. There are some legal things that people have proposed and have been implemented, including here in Colorado, that I'll just touch on. Workers' compensation. If you volunteer and you go to work somewhere else, say in another state, questions quickly arise around what happens if you get injured, because you're a volunteer now. You're not acting as an employee of your home institution. And so often states define volunteers from out of state as state employees by law. And that allows you to take advantage of that state's workers' compensation system should you become injured while volunteering. This is not uniform, and it's a problem. So the Uniform Emergency UEVHPA, Uniform Emergency Volunteer Health Professions Act, I think is what it's called. Colorado was one of the first states. I think there are 11 states that have now adopted this act, and it provides for some protections here. I think I have a slide on it here. So if you are in a state where this has been adopted, as Colorado has, it allows for licensure reciprocity across states. So your license is equally valid in another state that has passed this. It provides immunity from liability for actions that you take that are not egregious, essentially, but you can't be sued for malpractice in most instances during an emergency situation if you're a volunteer from out of state, and it provides some workers' compensation benefits. It does require that you be registered with one of the sort of legitimate disaster response organizations. And that leads me to the last point that I did want to make about this, which is I think all of you are trained people, and you have some degree of training in disaster response. The worst thing health professionals can do is show up at a disaster untrained and unprepared, but with what you think are skills. And this happens quite a lot. And it can be quite disruptive, especially in overseas disaster response efforts. If you've got a whole bunch of Westerners showing up in your, Haitian earthquake scene, who all demand a hotel room and clean drinking water and food, and those are resources that people there could have used, and now they're not available because we demand a lot of resources wherever we go. So being a part of a coordinated response effort is really important, and I think this is something, as teachers of this stuff, to medical students, to nursing students, and others, this is a really important thing to get across. Just showing up because you have finished your first year of medical school and you've got a few weeks off and there was just a disaster somewhere and I think I'll go help out in Peru, is you're more likely to cause harm than to cause good. Let me move to restrictions on liberty, and I'm gonna say a few words mainly about quarantine. Isolation is, and I apologize if this is really basic to you guys, but isolation is when someone is sick and they're put in isolation so that they don't spread their contagious illness to others. But people in isolation are already sick. Very little ethical debate about whether isolation is an ethically justifiable strategy when you're dealing with contagious illness and the person is already sick. People who are already sick don't tend to complain about being isolated either. Some do, but most do not, because they know they're a danger to others, and frankly, isolation is not their biggest worry. If you have SARS, being isolated is not the top thing on your mind in terms of what you're going to complain about. What is ethically problematic often is quarantine. And that's because quarantine is people who might someday become ill. They may have been exposed. Perhaps they were exposed, but you don't know whether they're going to become ill or not. And historically, the vast, vast majority of them will never become ill. Right? So China quarantined well over 100,000, Taiwan quarantined well over 100,000 people for SARS, of whom 2 were eventually diagnosed with having SARS. So when we do quarantine in these kinds of extreme circumstances, we're largely doing something which is not clinically very effective. So that's the sort of punchline. Now let me go through this for a second. So if we want to abridge someone's civil liberties in the U.S. as a result of a disaster or a contagious illness, the president has to declare an emergency. The HHS secretary has to declare a public health emergency. And at that point in time, the federal government can waive a couple of federal laws. So this is sort of the limits of what the feds can do without the states. So number one, the feds can waive EMTALA. And EMTALA, if you're not familiar with this, requires emergency rooms to stabilize patients before transfer. or to keep them, that can be waived in a disaster situation. The emergency room does not have to take in every single person and evaluate them before moving them on to somewhere else. Makes sense why this would need to be waived in a disaster situation. The other thing is the HIPAA privacy rule. And there are a number of provisions, specific provisions of HIPAA that are waived during a disaster. One of which, for example, is the requirement that the hospital get you or your family's permission before talking to other people about your condition. Stuff like that. So there are a number of things, privacy-related things. So they can set up showers outside without barriers between the showers and require that you take a shower naked before you walk into the emergency room. We don't normally do that. But in a chemical spill, you might need to do that, right? So those kinds of things can be waived on a federal level. Broadly speaking, the ethical issues related to the relief of someone's liberty rights in service to the larger community at first seem kind of stark. There's this trade-off that Ron Bayer famously said: the ethos of public health and that of civil liberties are radically distinct. That you can't do public health without abridging civil liberties, right? So you got to make this choice between losing your liberties and accomplishing your public health aims. And yet, as Ron and many others have noted, in many instances, it's a lot more complicated than that. And the best example that I've used, and maybe this is best to me because I'm an ID doc, is the HIV arena, right? So there were initial thoughts about, registering people who were homosexual, registering people who had HIV infection, quarantining people who were or isolating people who were HIV infected. And what people realized relatively quickly was that if you start removing people's liberties, that could backfire. Because what will happen is people who are HIV infected or at risk of being HIV infected will dive further underground. They'll disperse. And I'll give you another example of it. I'll give you another example of this in just a minute. So these are the principles that the public health community internationally has sort of put together as the types of things that should be considered when you're thinking about implementing a liberty-restricting intervention. Is it legitimate? Is it legal? Is it necessary? Is it non-discriminatory? And is it the least restrictive means appropriate? There are a number of other things that they suggested you should look at as well. Things like accountability. Is there due process for people to be able to get out of whatever it is? These are not absolutes, because due process, for example, just isn't going to work in its normal way during a disaster, right? You can't give everyone the same due process that you might normally wish to. These limitations on what the state can do or should do come directly from sort of the realm of political philosophy. This is famous Mill harm principle. The only purpose for which power of the state can be exercised over any member of a civilized community against his will is to prevent harm to others. Right? That's the standard libertarian view, actually. Your right to swing your arm ends at my cheek. You can do anything until it hurts someone else. If it hurts someone else, then the state has an interest in preventing that. That means, by the way, that we who might be proposing limiting someone's, restricting someone's liberty, not letting them swing their arms, should be predicated on effectiveness, number one. The only way you could justify limitations on liberty is if what you're talking about will work. So this gets back to what I mentioned before about quarantining hundreds of thousands of people. If it doesn't work, we shouldn't be doing it for sure, right? Because the only justification for restricting liberty is a utilitarian justification. It has to be useful. So whether things are useful brings up this whole list of other questions. Well, so what is it that might make quarantine useful or not? Well, it's not just, some of it's about the type of organism you're dealing with, right? So some things are amenable to quarantine and others aren't. So I'll give you an example. Influenza, which can be transmitted before you have symptoms, probably not amenable to a regional type quarantine, right? Because by the time, so if you tried to, if a new influenza strain, shows up in Denver, and it hasn't shown up yet in Kansas City, and you said, we're starting to see this, we're going to quarantine Denver. No one flies in or out of Denver, the roads are closed, we're leaving Denver alone, and the problem is, by the time you've seen it in Denver, people in Kansas City have been exposed. It's too late, right? So there are types of quarantines that might work or help, but a regional quarantine just won't work for a disease like influenza. What about SARS? Well, a disease like SARS, which it turned out, thank God, was not transmissible until after you were symptomatic, it made a little bit of sense, right? We didn't know that at the time, but the sort of biology of the organism will make a difference. There are also, though, a bunch of social characteristics that will determine whether a quarantine works, right? So we saw this with Ebola. Low social trust, quarantine will not work, and it might backfire. And this is where in Taiwan, I think I put the quote in here, Mark Rothstein did a review after SARS of how different countries managed the SARS threat and said officials in Taiwan now believe that their aggressive use of quarantine actually backfired. It caused people to leave town. So, for example, the Amoy Gardens apartment complex, which is where SARS was first noted in Hong Kong, I believe, they decided they were going to quarantine that entire apartment complex. It's an enormous complex. Sent the police over. By the time the police got there, half of the apartments were empty. So here's what happened. They threatened a quarantine, and it caused dispersal of infected people into the population. So it is possible for quarantine to actually backfire, right? And then there's this issue, the top quote is from Sam Nunn. This was a tabletop exercise called Dark Winter. Some of you may have heard of this. I want to say it was a plague exercise, but I don't remember for sure now. In any event, it was, I can't remember now if it started in Denver or it started in Salt Lake City, but it was a Western, I think it must have been a plague. In any event, it started in the West, and Sam Nunn from Georgia, nevertheless, he said, you know what? There are too many people with SUVs and shotguns. You are not going to be able to quarantine a city like Denver. It would never work, not given the American way of thinking, right? That because people in quarantine, often one of the things they worry about is, oh, great, you've locked me, because they're well, remember, these are not sick people, these are well people. And they're thinking, great, now you've locked me in a room with a bunch of sick people, I'm guaranteed to get it. I got to get out of here, right? Now, that said, the modeling on this, depends on both things, social factors and biological factors. And there are models that suggest even a leaky quarantine can work in some circumstances. So the place where this has really been demonstrated is with the pandemic flu, the 1918 flu. People have said, had they been able to even implement a modestly effective quarantine, it might not have changed a whole lot how many people got sick, but it would have changed the epidemic curve, right? So instead of the curve doing this, it might have done this. And that could be a big difference, actually. Even if the area under the curve is basically the same, flattening or smoothing the curve of an epidemic might allow us to not run out of ventilators, right? So there are reasons to try quarantine. And the other thing to be said about trying quarantine is that the public in the U.S. is actually very accepting in surveys of being quarantined. So despite what Sam Nunn said, which is undoubtedly true of some people, on average, 90% of Americans say, yeah, if there were a pandemic flu and I were infected, I would be willing to quarantine in place, to shelter in place, stay in my house, not infect other people. So most of us are pretty altruistic about this kind of thing. And then the third thing to be said is quarantine may sound like it's pretty ineffective pretty often, but you got to compare it to other opportunities for intervention for these types of scenarios. And for the types of things like SARS or Ebola, where there are not great treatment options, the other ways of managing it are equally bad or worse, right? So looking for people who are already infected through mass screening programs can also backfire, right? So I put up some of the data here. China screened 14 million people and found 12 cases. And some cases of SARS were linked to exposures that occurred while people were standing in line together waiting to be screened. So you were say something.
Legal protections if you're placed under quarantine that keep you from losing your job?
No. There generally are not, and that's you're one step ahead of me. No, that's exactly right. So here's where you go with this, right? It's actually got some analogs to the professional duty to treat conversation. So you got to start thinking about, so what are the barriers? Why wouldn't people? So pets. How are you going to use your food? Will you lose your job? What about your elderly parents, right? So if we as the public health community are going to say, we need you to stay in quarantine, it's really incumbent on us to make that as easy as possible. And some of these things are easier to deal with than others, right? So food and taking care of your pets, you can imagine quick solutions. Stigma, really hard. The fact that, many of the people in Toronto who were placed under quarantine came out of it symptomatic of PTSD. Right? And they experienced stigma like, you and I will probably never really understand because, SARS was extremely dangerous. And even though they never got it, they had the purple, star on the house or the red star, So we need to think about that. And the other thing we need to do is think about what you do in combination with quarantine and isolation type activities, because these are virtually never implemented alone. It's usually a sort of bundle of activities that is implemented. So, and this is, in surveys, 20% of people say, yes, I would be willing to go in quarantine, but I believe I would lose my job if I did. So now that means 4 out of 5 said I would not lose my job. So that means most people trust their workplace or their boss, probably. But 20% do not, and said, no, if I went into quarantine, I would lose my job. So this is the last point that I want to make about this, which is from this again is a SARS report, but it says it's a canard sometimes used to justify authoritarian actions, that the public responds to emergencies by losing control and panicking. In fact, the data on this are much different. The public in disasters and emergencies very often comes together and is quite cohesive, much more cohesive than in non-disaster scenarios. For an obvious example of this, think about 9/11 and just the political cohesiveness of the country that happened after 9/11, right? We never have a president with 90% approval rating unless someone attacks our country, right? So we come together by and large. The problem is, and I put this up here because, again, I'm talking to people now who may at some point be in a position to influence this kind of conversation. I think it's up to us to hold politicians back. And I say that advisedly, but the reality is politicians are the ones who may not have the background to really understand the peril of implementing a quarantine and the way that could actually backfire and be destructive both to public trust and to disease management. And they are under tremendous intuitive pressure and public pressure to do something strong, to be seen to be responding strongly to a public threat. So as a consequence, I think we're the ones who have to say, I know you think it's a great idea to, put every returning healthcare worker from, West Africa into quarantine for 30 days. We should not do that. That's a bad idea, right? We have to be the ones who can stand up and say that. Because if we don't, that's going to be because it just feels right. It just feels right. Like, why take the risk? Why not just everyone who goes to help out in West Africa, they all need to sit in quarantine for 30 days when they get back? Sounds safer. Well, it's not, right? And you and I know this, but the public in general, you got to take 3 or 4 logic steps to get there. And most people don't have the time, energy, inclination to take those 3 or 4 logic steps, including many in political life. So we have to do that. We have to say, look, if that happens, then we will have many fewer people going to help, which means the disaster there won't come under control, which means there's more opportunity for it to spread to other places. God forbid, it lands in Jakarta. If it lands in Houston, we can deal with it. If it lands in Delhi, we're in big trouble. So containing Ebola quick was a real priority. And the only way to do that is to have us there. So let me get to the last issue, which is I put up as the elephant in the room because it's the ethical dilemma that people most like to talk about with regard to disasters. That's resource allocation. So unlike, this is a quiz, pop quiz. Unlike in a usual practice, the only priority in a disaster is to save the most lives. So do you think, yes, that's true? During disasters, we switch our medical ethics. It becomes utilitarian. Normally it's not, but in disasters it is. Or no, medical ethics in disasters is fundamentally the same, although in a different context. Or C, I don't know, medical ethics is vague. It depends on what you think. A, the one utilitarian. B, 1, 2, 4. C, everyone else must be C. I don't know, medical ethics is vague. So there are a number of, I think my thoughts on this will become clear. I'm not going to give you an answer right now. There are a number of principles that philosophers and bioethicists and others have proposed. And these will be very familiar to you, right? Save the most lives. That is utilitarian, but it's not the only version of utilitarian, right? Because you could say, what about trying to save the most life years? That's a more nuanced version of utilitarian, right? So that would be children. That would be people who have a greater chance of survival would get more resources than people with a lower chance of survival, for example. What about the most productive or quality life years? So disability-adjusted life years, something like that. That would be an even more nuanced way to still be utilitarian, but to take into account a variety of other factors. But what about just women and children first? Right? That's a yes, says the woman. That's not exactly utilitarian. It's got some utilitarian flavor to it, right? Women and children are, they're the future, right? But it's not purely utilitarian. What about first come, first served? That's how we allocate resources a lot in the healthcare system, including sometimes during public health emergencies, right? I think this is 2008, when there was a big shortage of flu vaccine because the Chiron plant had that infection, and So we lost half of our flu vaccine, and this is how we allocated it. By and large, we had lines. So if you could show up early, we told people, try and give it first to high-risk people, but there was no one, enforcing any of that. And so we often actually had places where, one clinic had plenty of vaccine and a clinic 2 doors down didn't have any vaccine. So we don't have a way of allocating resources like that. Market-based. Why shouldn't we let people who can afford it buy the vaccine at a very high price? After all, you could use those dollars and reinvest them into, a boat or any number of other things.
Just wait 10 days.
That's right. So this is Zeke Emanuel's proposal, is the fair innings method of allocation, which is related to the idea of the most life years. So he said, there is value in passing through each of life's stages. So the more you have to go, the more resources you are deserving of. Because those of us who've already lived through 5 innings, we've got less of the game to play. So it's a fancy way of talking about aging, frankly. But there are a lot of other things that are often considered when people talk about resource allocation in crisis situations. First of all, the first step ethically should probably be to say, wait a minute, do we really need to ration right now? Or is there some better way of getting, of reallocating resources around town, right? So if Clinic A is having to ration and Clinic B has plenty, Clinic A's first job is to talk to Clinic B and find out, could we share? So that we don't have to ration as much as we are. There's something about compassion that is pretty compelling to us. There's almost, if you were purely utilitarian about this, and you had someone who was expectant, meaning triage, black tag triage, they're going to die. You expect them to die. Why not just roll them over to the morgue now and let them die there? You think anyone ever does that? Of course not. So even right? But that would be the utilitarian thing. Like, that's the lowest cost way to deal with this person who's going to become a dead body soon, is just roll them off to the morgue now and let them die in the morgue. Stop talking to them, stop feeding them, that would be utilitarian. Sorry, you're of no use to us. The fewer resources we can give you, the better we are, right? That would be the moral thing to do if you were a utilitarian. Because any resources you spend on this dead person, soon-to-be dead person, not dead yet, but soon-to-be dead person, any resources you spend on them are resources you can't give to person B who might survive as a result. So if you're a real utilitarian in a disaster, that's how you would do it. But no one ever does. And the reason for that is that we have these other things, these other values that also matter. And there's just no getting around it. Even if you wanted to be strictly utilitarian, I don't think we can do it. As human beings, we just are not built like calculators. We've got equity issues. We've got value issues. We've got the importance of the long run, right? Maintaining social trust and cohesion. If people thought that that's how you were going to treat them as they were on their deathbed, that might backfire in some way in the long run, right? So we have these other things. So with that as sort of the philosophical background, let me now say a word about the standard of care. So this is what the standard of care is, both legally and ethically. The standard of care is to perform to the highest standard a reasonable practitioner can achieve under given circumstances. So the standard of care is always dependent on context. Always. Which means, because the disaster context is different than the normal context, standard of care is the same in a disaster, but different. Because you can't do all the stuff you would normally do. So the quality of care you can deliver is lower. The standard of care is the same as far as legal responsibilities go. The standard of care is the same. but the quality of care is going to be different, and it's going to be lower, usually. Sometimes it's going to be a lot lower. Sometimes people you might be able to save in a normal context, you will lose because you're in a disaster context. And sometimes you will lose those people because of proactive decisions that you had to make about resource allocation, right? So the aim, according to the Joint Commission, the aim in a disaster situation is not to maintain the same quality of care you've always had. The aim is to degrade the quality of care in a graceful way. Graceful degradation of the quality of care. And what they're talking about is very challenging to implement, because we're talking now about, and these are things probably you've talked about before, the sort of supplies space stuff, staff space stuff. What are the resources available to you in normal operations, and then what are the sort of levels of capacity, right? So there's this gray, really. A wide range, starting with usual operations where you have all the normal staff, all the normal space, and all the normal stuff. And at this end, you've got catastrophic failure, where your hospital has been destroyed, you have no staff, no infrastructure, and no supplies. And every disaster situation will be somewhere in here, right? Almost never are you in this area, thankfully. But you're usually not in this area either. And so as regards decisions, what we're trying to do is create lines in this, granular world. So we're taking things like conventional operations, and we define them as being in this region, where, your supplies are low, your bed space is low, you've used up all your normal beds, you're trying to electively discharge people, you're calling in reserve staff, right? And that's still conventional operations. And then you've got this, which is contingency operations, which is where you're now reaching into your emergency stockpiles. All of your reserve beds have been activated and are full, and you're starting to put people in the hallways. And you're bringing in external staff. So this is where you are calling across state lines and saying, we need help. And then there's crisis operations. And in crisis operations, you may be reusing supplies that you would normally not reuse. You may be using all your hallways, and your file cabinets are being used to hang IV bags and so on. I've been in one situation like that at a health center, actually. I used to work at the Harvard University's health center, the student health center, and we had a Norwalk agent outbreak. We had like 300 kids in this little tiny center. So we were using all the administrative floors. We had kids laying on the floor. They were fine, but it was, we were using all the hallways. And then, you get into this area where it's unsafe, and you really need to just get people out. So this is what the Institute of Medicine has defined as crisis standards of care. And I have to say, I was a reviewer for this report, and I work with the group that produced the report now. I've always been troubled by this terminology because it sounds like the standard changes when it doesn't. It's the crisis that changes things. Nevertheless, we were able to get them to write this in a way that I think is quite accurate, which is this is when a substantial change in operations is made necessary by a pervasive or catastrophic disaster. So these are not options. You don't choose to implement crisis standards of care. Crisis standards of care are thrust upon you, right? So, and then they gave a bunch of sort of values that should guide behavior and decision-making under crisis standards or under crisis situations. And I will just say, I think these are perfectly good as a starting point, but one of the things that every state ought to do, and in fact I'm on a working group now here in Colorado to do just this, is to look at community engagement. And in fact, I think next week we have our first sort of midpoint meeting for community meetings that are going on around the state right now to talk about managing resources during a disaster. And it may be that these are the values that our, officials and state sort of representative type people come up with, but there may be others that are also important to us here in Colorado. This is the basic dilemma, though. Patient A is on a ventilator. Patient B needs it. You don't have another one. So your choice is to leave patient A on and let patient B die, or to take patient A off in the hope of saving patient B's life. That is this is Sophie's choice. There is no easy answer to that. There's no obviously ethical answer to that. But it is important to recognize withdrawing the ventilator from patient A is not euthanasia. Right? It's not. It's withdrawing treatment, which is not euthanasia. It's withdrawing treatment that is necessary to sustain life. It's not euthanasia. Euthanasia is when you actively kill someone by administering something, right? It's a new treatment intended to kill. Excuse me. Providing them subsequently with palliative care is not euthanasia. Tagging someone as expectant is not euthanasia. So, I forgot. Thank you. I knew this would come in handy eventually. So, these are deeply discomforting choices. It would be weird if they weren't. It would be wrong of us not to be really disturbed by these. But they are forced choices. And it's not better, therefore, to let patient B die because patient A is already on. Right? That would be that would be falling prey to the default bias. The last thing to be said about this is following Katrina, there were some issues around volunteers who had, this is being recorded, so I'll be cautious in how I say this, they had probably done some things that are ethically questionable. And the issue became, so how do you hold someone to account? Or doing something which may be ethically questionable, maybe even legally questionable, but in an environment where you're really glad they were even there to begin with, to be providing care. And do we really want to hold people to sort of usual mechanisms of accountability when they are making decisions, gut-wrenching, difficult decisions, under circumstances that most of us can't even understand because fortunately, we will never be in those circumstances and have to face those kind of decisions. And the answer from the AMA and the American Nurses Association was basically no. We should not hold people in those types of circumstances to the usual mechanisms of legal accountability. That it's just, it's not the right mechanism. And the criminal prosecution of people following decisions they make during a disaster should be exceedingly rare, if ever allowable. So this is the quick summary on resource allocation, that we should try to use limited resources fairly. By the way, we should try to do this all the time, not just during disasters. And one of the things that I hope comes out of the broader conversations that are happening now, and have been happening for a few years now, about so-called crisis standards of care, is that we start looking more broadly at how we allocate resources across the healthcare system in general. If we can have fair allocation of resources during disasters, why not have fair allocation of resources today? And maybe some of the same ethical principles and protocols should and could be used. The last point on this slide is just to avoid ad hoc decisions by individuals. This is where people really do tend to get into trouble, is when they're making decisions without really fully consulting with colleagues and others. And in particular, it's bad if they don't have good situational awareness. So if someone in the hospital is making a decision about reallocating a ventilator, but there is a hospital, in town with an extra ventilator, you could imagine this situation going in a disastrous way because you didn't know that there was something else available. So that's the last point on that. And this is just the summary. So I will stop there. And I think, unfortunately, I ran right to the hour. I apologize. I did not intend to do that. I'm happy to stand outside the door and talk.
It's interesting that under the, you talked about quarantine.
If you wouldn't mind, I've
Yeah, I understand. Sorry. Yep. Yep.
a bunch of rent.
School closures.
Yeah, because in Mexico,
we have to go to Bali because we bought our airfare to Bali first, and we're flying back out of Phnom Penh, Cambodia. So like, I don't know. Huh? Yeah, so we're gonna go. Yeah, we're gonna spend 2 days.